Okay, let's talk about Marfan syndrome. It is again one of the conditions within the autosomal dominant disorders which affect primarily the skeletal system, but we'll talk about it in much more detail. So, autosomal dominant disorder, Marfan syndrome. So, one cause, autosomal dominant. Okay, not all the people who have Marfan syndrome not necessarily have autosomal dominant variants, but again, in about 70 to 85% of the cases, it is autosomal dominant. In about 25% cases, it is de novo. Okay, there is about 25%, 20 to about 25% it is de novo. What does it mean by de novo? De novo means patient who has Marfan syndrome but does not have a family history. So in this there is no family history. Family history is absent in this case, or let's make it negative. So family history will be negative in this case. Now this is a disorder which affects primarily it affects the connective tissue. So it's a connective tissue disorder. And when I mention that it is a connective tissue disorder, it affects primarily the connective tissue. The connective tissue itself is widely distributed in our body. So before we go on further on Marfan syndrome, we must understand what is connective tissue, where it is distributed, and how it is distributed. Okay, uh, let's first talk about some general things, then I'll talk about connective tissue again. So its prevalence is about 1 in 5,000 people. Okay, also the gene affected in this case is your FBN1. So gene affected is FBN1 gene. This fibrillin 1 gene, it is called as fibrillin 1 gene, which codes for fibrillin 1. Okay, now there is one doubt in most people's mind. They always try to correlate Marfan's with EDS, Ehlers-Danlos syndrome. In Marfan syndrome, the fibrillin 1 gene is affected. Okay, however, in case of Ehlers-Danlos syndrome, in case of EDS, it's collagen. Okay, so one point to remember in this case, Marfan syndrome is fibrillin 1, and for the EDS it's collagen, right? So what is actually happening in this case? Fibrillin 1 gene codes for fibrillin 1, and because it's a gene, it will be located on some sort of chromosome. Okay, so chromosome in this case will be fibrillin. Name says fibrillin, so it's a kind of 15, right? So chromosome number 15 is damaged, distorted, mutated somehow. Within the chromosome 15 also, just for an extra edge if you want to remember, it's chromosome number 15, which part? Q part, and 21 segment. This is just an extra edge. If you want to remember, you can remember. If you don't want to remember, that's also fine, but just remember it is found on chromosome number 15. Right, now I just mentioned about Marfan syndrome. There's also one more case in which not FBN1 but FBN2 is affected. So FBN2, and this FBN2 is a gene which is found on chromosome number 5, Q part, 23 segment, and 31st part. Okay, I don't know how to nomenclate about the chromosome part, but anyway, you got it right. So this is not about Marfan syndrome. This is just an extra point. If you want to remember, you can remember this fibrillin 2 gene, right, which is on chromosome number 5q. This causes CCA, right? CCA, which is congenital contractural arachnodactyly. This is just to remember, because at the end I'll tell you about what is CCA and how it is correlated with Marfan syndrome. Right now, we just mentioned about CT disorder, right? It is a kind of CT disorder, connective tissue disorder. Let's first talk about what is a connective tissue. So connective tissue within our body are of different types. Connective tissues are connecting tissues. Connective tissue disorders, the Marfan syndrome, affect the connective tissue. Within the connective tissues also, there are different types of tissues. These are widely spread. Almost every organ has these, or its form at least. So connective tissues are of different types. First one is CT proper. Or Marfan syndrome affects one of the parts of connective tissue proper. The connective tissue proper are of two different types. Okay, two different types. It can be loose, it can be dense, right? Then in the connective tissue there's again cartilage. I'll not be talking about connective tissue in much more detail. I'll make a separate video on it for only all those important things in the connective tissues which is related to our disorder. We'll focus more on that. So cartilage and bone, and also we know that the bone are again of two different types, compact bone and this spongy bone. And lastly there is blood. Blood also again have plasma, RBC, WBCs, and blood and lymph. So again lymph is blood minus all the different cells which are plasma, RBC, WBC, and platelets. All those were blood. In the lymph, blood minus all those cells except the WBCs, right? Then there is again plasma. We'll talk about all of them in separate lecture. So right now we'll focus more on CT proper. Our Marfan syndrome affects majorly the CT proper. And how? We'll see that. So it affects majorly the dense connective tissue proper. So how the dense and the loose differ from each other? The loose connective tissues has more cell and less fibers. The vice versa is in dense. So there are more fibers and less cell. In the Marfan syndrome, it somehow affects the fiber. So because there are more fiber in the dense, the manifestations are much more seen in the dense connective tissues, right? Now within the dense also, there are again of three different types. Okay, it is again of three different types. It can be dense regular, it can be dense irregular, and it can be elastic type. In the dense regular, it comprises of tendons and ligaments which provide the tensile strength in the direction in which they are oriented, right? So let's say if this is a bone and there is a muscle onto it, it has to connect to the separate joint. So the orientation of fiber will provide the tensile strength in that particular direction. Then in the case of dense irregular, it is commonly seen in skin, much more particularly and dermis of skin. Now because of this, it provides stretchability of fibers in all different direction. Okay, you can stretch this particular fiber in all the different direction. Let's say this is the part of that dense irregular connective tissue. Okay, if you provide forces in all the different direction, it still has an ability to stretch to a particular limit. And lastly, we have elastic type. Within the elastic type also, it affects more of large arterioles or arterioles, large artery and arterioles. Then it also affects some elastic ligaments, and it provided the stretch and recoil. Very important point: stretch and recoil. Saying that, we can think that this elastic type will be found in different systems: cardiovascular system, then there can be respiratory system, and also the ligaments suspended in the eye, ligaments of eye, particularly the lens, so the suspensory ligament of the eye in this part. Now I just mentioned all these things, that it affects the Marfan syndrome, affects the tense connective tissue proper. So we can just make a thing. Okay, what thing? We can say that there's a sort of triad. There's no actual triad, okay, again, just for this lecture's sake. The Marfan syndrome, okay, this Marfan syndrome affects three main structures or system of the body: skeletal system, okay, affecting the tendons, ligaments, joints, okay, tendons, ligaments, joints, fibers, like that. Then it affects the eye. Also it affects majorly the cardiovascular system. Also side by side it can also affect your respiratory system, okay, and followed by skin and joints. Okay, why? Because of problem with dense connective tissue, proper, okay, and because of its distribution. Right, so we already discussed about the fibrillin 1, which is affected in this case. So this is very, very important. Most of the questions are asked which gene is affected, which protein is affected. So this part is very, very important, and how it is different from EDS, Ehlers-Danlos syndrome. In EDS, more collagen is affected. In Marfan, fibrillin 1 is affected. Right. Now, as we were talking about the fibrillin, okay, let's talk about fibrillin. So fibrillin is a protein. Okay, let's say it's an protein. This is the protein. Okay, let's not make it like this. Let's make it from red. This is a protein. If this is a protein, there is some sort of cell which will be forming this, right? So let's make it like this. This is a cell, okay, within our body, which produces the fibrillin 1, okay. This produces this fibrillin 1, and onto this fibrillin 1 there's again some topo proteins which binds onto it and make it elastic, or whichever the property it want to give to this protein, right? So these are your topo proteins. And which is this cell? This cell is none other than your fibroblast. Now this fibroblast is amazing. Okay, it makes different types of proteins. It can make your fibrillin. So let's say this is your fibrillin. There is also plenty of other work this fibroblast does. So let's say this is our fibroblast. It does plenty of work. First of all, it makes 3 important proteins. Your C, E, F. Sequence is A, B, C, D, E, F. So C comes first, then E, then F. So C stands for your collagen, then E for elastin, and F for fibrillin. Great. So this is important, these 3, right? And side by side it also makes different other things. So it produces the TGF beta, transforming growth factor beta. It also produces metalloproteases. It also produces VEGF, vaso-endothelial growth factor, and the FGF, which is our fibroblast growth growing factors. And lastly, the same fibroblast. So this was fibroblast, and these fibroblasts are widely distributed in your body. These fibroblasts again produces different types of GAGs. GAG, glycosaminoglycans, right? There are different other types of glycosaminoglycans. These are your HAHS, then CS, DS, and here KS. If we'll not talk about these GAGs, just remember that these GAGs act as a ground substance and it tries to hold water, right? So let's say we have tissues with different types of cells in it, and within these cells we have GAGs. Okay, let's not make it with this. Let's say we have GAGs. Again, different GAGs have different function. We'll talk about GAGs in some separate other lecture. So we know that whenever there is a tissue, there are cells, then there's most of them, the intercellular space is filled with fluid, right? So the function of these GAGs is that it surrounds, okay, it surrounds these collagen, elastin, and fibrillin, right? So these collagen, elastin, and fibrillin are in these intercellular spaces, and it provides that tissues with the particular type of characteristic feature, depending whether it's a collagen, elastin, or fibrillin. It gives tissues that kinds of function, right? So CEF, collagen, elastin, fibrillin, will be deposited here in this space, right, along with the GAGs, and these GAGs will help us to hold water in this area, right? So you have a kind of idea what is actually happening at the tissue level. Now let's talk about this collagen, elastin, and fibrillin. We'll focus more on fibrillin, but still all the tissues have almost always, all the time, all these 3 proteins, right? So all these are protein, but all the tissues again varies. Why? Because in some tissues collagen is more, elastin is less, fibrillin is almost 0, Then in some we'll have elastin more, fibrillin at the moderate amount, and no collagen at all. But just for an example, right? Almost collagen itself is the like most abundant protein in our body, right? So let's talk about collagen first. Collagen is a fibrous protein. This is a fibrous protein, although the name fibrillin make us think that it is a fibrillin protein, right? Anyways, the elastin is an elastic protein. Elastic protein, as the name suggests, it will provide the elasticity. The fibrillin, again, it's a type of glycoprotein, which means that it has glucose and protein in its structure, right? Now what's the function of them? Fibrous protein provides the tensile strength. The elastin protein will provide elasticity and recoil, right? So we can suspect which structure will have which sort of protein. The fibrillin, again, it has microfibrils, so it has microfibril, and because of this it supports the elastin. And how they actually looks like. So the fibrillin has a microfibril structure. Okay, the elastin, again, it has no particular structure, it is a random structure. And lastly, for the collagen, it has a triple helical structure, right? So triple helical structure, just make a DNA and one more strand in it. This is your collagen. Let's see if one day I will tell you how collagen is produced. Anyways, all these are produced by the fibroblast. Now, as we have discussed this, let's see which different structures it is distributed. So first one is collagen. Again, widely distributed, almost all the tissues have it, but the amount, again, actually help us to differentiate it. So collagen is seen more in skin, bone, tendons, cartilage, and the blood vessels. The list is huge. This is just a small version, just for an example, just to help you understand what is actually going on. For the elastin was helping us for the elasticity and recoil. So skin, then ligaments. The ligament is more stretchable than actually the tendon. So anyways, again, lung is elastic, and arteries, within the arteries also medium size and plus arterioles, not in the veins, right? And lastly, for the fibrillin, as it was supporting the elastin, so all those structures which again has elastin will at least have the moderate amount of fibrillin along with it. So aorta, eye, skin, and again ligament, almost same. These two have almost same distribution. Finally, let's see the disease. So this was almost same distribution. Anyways, finally the disease, disease. Anyways, so first, for the collagen, it is EDS, Ehlers-Danlos syndrome, and osteogenesis imperfecta, right? For the elastin, although the distribution for the elastin and fibrillin is almost same, but the diseases affecting them are different. So first is cutis laxa, and supravalvular aortic stenosis. Supravalvular aortic stenosis, SWAS. Okay, supravalvular aortic stenosis. And lastly, for the fibrillin, most classic disease is your Marfan and our field of interest, right? Good. So the quantity of all these collagen, elastin, and fibrillin in the different tissues will provide which type of connective tissues it will be and which sort of properties it will possess, right? So we were talking about the fibrillins, right? So fibroblast was depositing um, the elastic fibers. These elastic fibers was again bombarded with topoproteins. In this case, it is tropo. So for the elastic proteins, okay, it can be fibrillin or elastin, doesn't matter. So topoelastins, okay. Which kind of protein is it? It is a type of topoelastins. We don't need to remember, but just for an extra edge, this is just an extra edge. If you want to remember, you can. If you don't want to remember, fine, but at least remember fibrillin. What is it actually and how it functions? So now let's talk about the pathophysiology, what is actually going on the patient. So we were just saying that the patient has problems with fibrillin formation because of defective fibrillin 1 gene. Now because of this, the fibrillin protein, okay, because of defective, okay, let's write it over here, defective fibrillin 1 gene, okay, defective fibrillin 1 gene will give defective fibrillin, okay. Now this defective fibrillin formation can be in two different ways. Either the quality is decreased or distorted somehow, or overall the quantity is decreased. In both the cases, it is actually cause the TGF beta signaling to go crazy. Okay, it will increase. Okay, remember TGF beta? Where is TGF beta? So this, okay, this will go crazy, and because of this, it will cause increase in metalloprotease enzyme, right? So more the metalloprotease, then there will be more amount of metalloprotease in the extracellular matrix, ECM, extracellular matrix. So this is the problem with the patient. Now let's see the problem associated with the MFS. So there was, in the first slide, I guess, we just talked about, the first one was FBN1 gene, okay, this one. The second was one FBN2 gene, right, which was causing CCA, congenital contractural arachnodactyly. Again, that name was same, okay. Now the point again an extra edge, point to remember. The Marfan syndrome, the one which we're talking about till right now, was MFS1. This one, the one I'm talking about right now, is MFS2, Marfan syndrome type 2. In this case, there is defect in TGF beta receptor, type 2, and there is mutation, okay, mutation at this level, and because of this there is over signaling, okay. The same thing will cause TGF signaling again, right, which will again lead to same metalloprotease condition, right. So this is a rare variant of Marfan syndrome. So let's write it over here. So my point was that our classic Marfan syndrome was MFS1, which was caused by FBN1 gene mutation, and this MFS2 is a different variant which is caused due to TGF beta receptor mutation. Okay, so while diagnosing we have to find out what is actually the cause of it. So MFS1, MFS2, this is the classic one, this is again a variant. Okay, in the first part it was due to FBN1 gene, fibrillin 1 protein was affected, and in this case it is due to TGF beta receptor type 2 malfunction, and because of malfunction there is over signaling to TGF beta, right. So in the previous slide we just talked about a kind of triad. Okay, this is not an actual triad, again I'm telling you, but just for our reference it will help us to make a diagnosis. If a person is getting affected, if the patient's skeletal system is affected, primarily the tissue, the tendons and ligaments, the ocular part, how the ocular part, we'll talk about it, okay, and the cardiovascular system along with respiratory and skin and joints, more commonly the cardiovascular followed by the respiratory and then skin and joint. Okay, good. Now let's talk about the clinical features. So it were affecting the skeletal, the ocular and the cardiovascular, then along with the respiratory and skin. Okay, so this is a formula, small formula. So first one, skeletal. Within the skeletal the patient will have again tall stature, all those dense connective tissue proper tissues are affected, so tall stature. Second is arachnodactyly, then chest is affected, so pectus, there can be two different variations in it, excavatum and carnivatum. Hope I'm writing it correct, carnivatum, that is a pigeon chest and a deformed chest. Okay, this is your, normally the patient should have like this, the patient chest is either this is the anterior, this is the posterior, either the chest of the patient bulges out like this. Okay, this is one variant, or the patient chest can go inward. Okay, depending on that the patient will have pectus excavatum or carnivatum. Anyways, next is scoliosis, kyphosis, lordosis, all these spine deformities, spine alignment deformities. Okay, scoliosis, kyphosis and lordosis, patient will have high chances of having this. There's no need that all the patient will have all the symptom of the skeletal system, but you got it right. Hypermobility, I have one picture, okay, depicting how this hypermobility actually looks like. Then the patient will have high arched palate. Okay, then second is ocular, ectopia lentis, that is your lens dislocation, and because of this the patient will have increasing power in the lens, glasses, or even complete blindness can be there because of this. Then there can be severe myopia, remember, changing of the power of lens. Then there can be retinal detachment, There can be also glaucoma and cataracts. Okay, so at least these points you must keep in mind while making a diagnosis. And lastly, for the cardiovascular system, which was more important, right? So aortic aneurysms, because the CT proper dense was seen in arterioles, so aortic aneurysm is much more common. Aneurysms, plus they can also be cases of dissection, which is again more lethal. High mortality rate is seen in that case. Then mitral valve prolapse can be there. Then there can be aortic regurgitation, and different types of other regurgitation can also be seen. Also arrhythmia is much more common, right? The cardiovascular system is more common cause that causes high mortality in Marfan syndrome. Okay, in either way, in either case of MFS1 or MFS2, doesn't matter. If the patient have this and the patient is kind of fucked up. Anyways, then there can be increased amount of stretch marks. Stretch marks will be high in that case. Also there will be high chances of hernia, right? Then our lung was also getting affected, right? So lung or our respiratory system. So because the elasticity in the recoil is affected, there is a restrictive lung disease, much more common, and spontaneous pneumothorax. They can also cause disease, but slowly. This is much more lethal among the respiratory type. Anyways, now let's see how to make diagnosis, differential diagnosis. One more thing. Not that common, but again, one more feature, that is your dural ectasia. In this case, the enlargement of spinal dura takes place. Enlarged spinal dura, and because of this, pain, okay, headache, back pain can be seen. So pain can be of headache or back pain. Okay, now let's see how to make differential diagnosis. Whenever the patient with all these features comes first to us, we have some bad habits. And what are those bad habits? That we think, oh my god, the patient will have EDS. Okay, so this is one of the differential diagnosis. Then there can be acromegaly. These are our bad habits. We don't think, we directly come to the conclusion that the patient will have EDS or acromegaly. But again, there can be different other causes of it. So they can be marfanoid habitus. The patient looks like that. Why? Because there is problem with the amino acid pathways, particularly the homocysteine. Okay. Then there can be CCA, right? The same problem goes on in this case also. Congenital contracture arachnodactyly. Then men 2B also present with the same condition. Then LDS, that is your Lois Dietz syndrome. There is a mutation in your TGF beta receptor 1 and 2. Okay, so TGF beta receptor type 1, type 2, same problem already discussed. Then your Klinefelter. Right, so these are at least These are the disorders which you should keep in mind before making a diagnosis. Now, how to make a diagnosis? Let's see how to make a diagnosis. Patient comes with all these things, with some problems. We check for Ghent nosology. Now, Ghent nosology, just remember the name. Nobody's going to ask you what is Ghent nosology. Okay, the name. Okay, but what actually it contains, it is important. So first of all, most of the cases will have positive family history, about how much, 80 to 85%. So positive family history will be there for MARFANS. Okay, then clinical features will be positive, all those, not all those, but at least majority of them. And the genetic testing will be positive, right? So the Ghent nosology says that in order to make a diagnosis, we focus firstly on family history. So either the patient will have negative family history or the positive family history, right? If the patient have positive family history, then ectopia lentis or aortic root dilatation followed by aneurysms, right? And the other thing apart from all these two, okay, other things are your systemic scores. Okay, so all these clinical features we just talked about, all these are your clinical or your systemic scores. Okay, these are your systemic scores. Any one of them gives one score. So along with all this systemic score, SYS, systemic score of more than equals to 7. In this case, if the patient have a positive family history, if the mother, father, siblings have the disorder, then we go with this part. Okay, if there is no family history, then we check for this Ghent nosology. So first of all, we check for so many things to make a diagnosis of Marfan syndrome. First of all, aortic root dilatation, okay, and ectopia lentis. Overall, the Z score, this is just a scoring pattern, don't need to remember, just know this. There's something called as Ghent nosology, just that for that sake I'm just teaching you. Ghent score, Z score is more than or equals to 2. Then again, aortic root dilatation plus FBN1 mutation is positive. Okay, the Z score will be again equals to greater than or equals to 2, and the aortic root dilatation plus systemic score of more than equals to 7, then you are kinda fucked up again. So, okay, so these are kind of criteria we can use to make the diagnosis, right? And then we can also check for we can go with the ECG to monitor the heart, right? ECG and CT MRI in order to check the complexities of cardiovascular system, because first thing that will kill this patient is your cardiovascular system. So first thing first, go with this. It will actually help us to assess the severity and how much the patient is yeah, you got it. So ECG, CT, MRI. Then we can also check for slit lamp for your ectopia lentis slit lamp examination. Then we can also check for X-ray and MRI for ligaments and tendons and so. So the MRI of spine, this will again help us for duro-lactasia. Right. For the genetic testing, this one was genetic testing, right? In the genetic testing, we can check for the FBN, either positive, or FBN is positive, or we can check for TGF beta. The molecular analysis we can go for, we can check for the TGF beta 1 and the TGF beta receptor, receptor 1 or 2, to rule out that Loeys diet syndrome. Right. Probably the second last slide, then I'll show you one important picture. Okay. For the treatment and management, no treatment. Again, no treatment. So the first one is to decrease the mortality. By decreasing the mortality and the problem with the cardiovascular system, we can give the patient some beta blockers, ARBs, avoiding some strenuous exercise, right? If there's MVP, some other problems, you can go with the surgery in cases of severe problems, right? This one was for cardiovascular. Now for ocular problems, glasses, you can use lens, and again surgery if there is already ectopia lentis, so in severe forms, right? Then we can try to provide some good things to this affected individual. That is, if there is scoliosis, lordosis, that problem, bracing of spine can be done, postural correction and moderate amount of exercise, at least the postural fixing exercises can be done, postural fixation can be done. Then physical strengthening, because no exercise is worse in this case. Moderate will be still helpful. Again, counseling, because of all this the patient may have some other problems, so counseling for all those. And lastly, we just said that previously the patient have this MFS1, MFS2, and overall what actually happened is that there is, in both the cases, in MFS1, MFS2, either the problem is with FBN1 or TGF beta receptor 2. In both the cases, this is happening. What is happening? This thing. So we, not me, our smart individuals made a drug. I guess it is still in clinical phase. Anyway, there's a drug drug is formed, manufactured, which is actually a down regulator, okay, for this TGF beta signaling pathway. What is that drug? That drug is frisolimab. So frisolimumab. This is, and again, monoclonal antibodies. This is a drug which is in process, I guess. This actually down regulates this path. This was your pathophysio. So frisolimumab downregulates this TGF beta signaling pathway, and because of this, less amount of metalloprotein is formed, and overall the condition is actually getting better in the tested individuals. So for the treatment option, we can keep this medicine with us. Medicine was frisolimumab. keep this thing in mind. Good. Now, I guess last slide. One important picture. Where was that picture? These two. Right. So these are two pictures we must keep in mind. We already discussed about ectopia lentis. Okay, there can be malar hypoplasia, detachment anophthalmos, crowded teeth can be there, nasal speech can be, they can be nasal speech, they can be high arched palate, pectus excavatum, carnavatum, right? There can be problem associated with the cardiovascular problems. The patient will have overall long stature. There can be tall, thin body, scoliosis, kyphosis can be there. Dural ectasia can be there, and because of this, there can be compression to nerves and problems associated with it can be seen. Stretch marks, okay, striae atrophicae. Then there can be disproportionately long legs can be there. There can be joints hypermobility. There can be long finger arachnodactyly can be there. Right. So this is one of the features we just keep in mind whenever the patient enters the clinic. Okay, we should see all these things. Okay, now general rule. Okay, this is not so much hard and fast rule. General way, right? To check the patient. This is our Steinberg sign and Walker-Murdoch sign. So this Steinberg sign says that the thumb projected beyond the borderline of the ulna. So this part is, more. So this is your ulnar side, right? This is your ulnar side. This is your radial side of the hand. So the projection of the thumb will be more, okay, extending way beyond the ulnar region, ulnar part of the thumb, of the palm, sorry. Then there is Walker-Murdoch sign. If you take your fifth phalanx, so this is your fifth one, this is your first one, and if you are able to reach, okay, and if you are able to touch this first and fifth at the wrist point, then there is high suspicion. However, in most of the individuals, even if they are normal, they can do this. But anyways, yeah, so this is again a general way you can use to make a diagnosis. Not a diagnosis, we can use this to make a suspicion. Along with this image, go with this. Oh, let me remove this page. Anyways, along with that diagram, remember all these diagnosing things about the Ghent nosology. Go with the genetic testing, family history, have this aortic root dilatation, ectopia lentis. This is your EL, ectopia lentis. This is your ARD, aortic root dilatation. This will help us to make a diagnosis. I guess this was all. We'll next talk about probably the Ehlers-Danlos syndrome. Yeah, that was all. This was a kind of a long lecture. But anyways, please read about this slide. This is very, very important. I know I just wasted a lot of time just for this fibroblast thing, but important. This page is important. If you know this thing and the distribution of this page also, this is also important. This will help us to sail your boat right through the thunderstormed ocean of this Marfan syndrome. right? So dense connective tissue proper, right? Thank you for